Our next speaker is Donna McDonald-McGinn, who is the director of the 22q Center-in-Chief of the Genetic Counseling Section at Children's Hospital of Philadelphia. As chair of the 22q 11.2 Society and a founding board member of the International 22q 11.2 Foundation, she leads global initiatives focusing on chromosome 22q 11.2 copy number variants. With over 350 publications, including textbook, she specializes in understanding outcomes in patients with chromosome 22q 11.2 deletions and variants, particularly TANGO2 Deficiency Disorder. Donna currently serves as a member of the T2RF Scientific Advisory Board. Please join me in welcoming Donna McDonald-McGinn.
Thank you so much for that introduction, and thanks so much for having me. It's such a pleasure to join the 22q and TANGO2 communities. Now, Dr. Sacher mentioned that he was standing between you and lunch, and I'm well aware that I'm standing between you and the wonderful world of Disney. So I will keep moving. I do have some disclosures that I'm a National Medical Advisory Board member for NATERA. As you heard, I'm a founding board member for the International 22q Foundation, which is the family organization, and I'm a founding board member and current chair for the 22q 11.2 Society, which is the scientific organization. So in a relatively quick amount of time, I'm going to provide an overview of 22q, including the background and history, some etiology and prevalence, associated features including overlap with TANGO2, and of course the importance of TANGO2, which is what you're all most interested in. And as Dr. Lalani mentioned earlier, before we talk about things like chromosomes and genes, we need to step back and talk about cells. So what I'd like to do quickly is just talk about the fact that all living things are made up of cells, including this leaf, and you can see the cells visible as boxes, and all humans are made up of cells. And as you also heard earlier, chromosomes are located within the nucleus or the middle of the cells, and they're visible under the microscope. And we expect to see 46, we don't always. And in the old days, I'm dating myself, we used to take a photo of them and we cut them out and we lined them up and we made something and called it a karyotype. Computers do that for us now. And within a karyotype, the chromosomes are arranged in 23 pairs, numbered from the largest, which is number 1, to the smallest, number 22, and includes the sex chromosomes. So on the left, you can see a male with an X and a Y, and on the right, a female with 2 X chromosomes. Now, all chromosomes have a top and a bottom half that's separated by a waist called the centromere. And chromosomes were first described by the French, and they noticed that the top was always smaller than the bottom. And so they called that the petite arm, or P for short. So Q follows P in the alphabet. So in genetics, when we say 22q, everybody knows we're talking about the bottom half of the chromosome. And chromosomes are further defined by a numbering system that names the individual bands or stripes when we stretch them out like an accordion. And this creates a universal language. So 22q11.2 is completely different than 22q13.2. And chromosome bands are like the boxcars on a train. If a train came into the station and when you were looking at it, if a boxcar was missing, if you expected 11 and there were only 10, you'd see it with your eyes. So likewise, with chromosomes, if a band is missing or extra, we generally see it under the microscope. But the genes are the packages inside. So if a chromosomal band is missing or extra, genes are missing or extra. And genes, as you know, set up the blueprint for how the body is formed. So the chromosome 22q11.2 deletion involves missing genes. And in general, about 50 genes are missing in total, and this is a representation of those genes. And loss of these genes results in a multi-system disorder with significant medical problems and some mortality. Now, TBX1 is one important developmental gene, and it affects the developing embryo. So it results in abnormalities of the heart leading to cardiac differences, so structural differences of how the heart's formed. Differences in the thymus, it's too small or it's absent, leading to immune problems, and differences in the parathyroid glands, which control calcium and lead to low calcium. Now, in 1965, Dr. Angelo DeGeorge, shown here, who was an endocrinologist in Philadelphia at the other children's hospital called St. Christopher's, he first described features now known to be primarily caused by a chromosome 22q11.2 deletion, and there are other causes of these features as well. But they included low calcium and a poor immune system initially, and then congenital heart disease was added, and that completed the triad that came to bear his name, which was DeGeorge syndrome, and the word syndrome just means collection of findings. 16 years later, this child was seen at the Children's Hospital of Philadelphia with features of DeGeorge syndrome, so that typical triad, but she also had an opening in her palate called a cleft, and she had a gastrointestinal abnormality. Laboratory studies revealed only 45 chromosomes. I told you you're supposed to have 46. And it included a rearrangement involving chromosomes 10 and 22, and that resulted in a piece missing on both of those chromosomes. Thereafter, additional patients came to attention with rearrangements involving chromosome 22. So the conclusion was drawn that a deletion on chromosome 22 was a cause of DeGeorge syndrome. Now, from 1982 to 1992, deletions under the microscope were seen in about 25% of patients, but the puzzle remained, what about the rest? This led to the development of FISH probes in the early 1990s by Pete Scambler in the UK, shown here, and Debbie Driscoll at CHOP. And they used fluorescent probes that lit up when they found their likeness in the cell. So by inference, if the piece didn't light up, it was missing. And this identified deletions too small to be detected by just looking under the microscope. And 22q11.2 deletions were then found in the vast majority of patients with DeGeorge syndrome. Now, importantly, FISH probes are located between the A to B region of the deletion. You see A, B, C, and D. Now, most patients have what we call a standard typical deletion, which extends from A to D. But patients with smaller deletions outside of A and B will be missed by FISH. And this is particularly important because there were patients that looked like they should have the deletion, but they were negative by FISH. But also important is that these deletions do not include the important genes TBX1 and TANGO2. And so if we're thinking about symptoms related to TANGO2, it's important to know the size of the deletion in the patient with the 22q deletion. Now, once the 22q11.2 deletion was identified in patients with DeGeorge syndrome, it was then found to be the cause of multiple other clinical diagnoses. So patients with velocardiofacial syndrome, which added the palatal differences and some differences in craniofacial features, conotruncal anomaly face syndrome, which was essentially the same thing but described by the Japanese. We described a subset of patients with Opitz-G-BBB syndrome that had wide-spaced eyes, cleft lip and palate, which had not been described before, abnormalities of the larynx and trachea. And then the Italians described Kähler cardiofacial syndrome way down on the lower right with asymmetric crying faces. So you can see when that child's crying or smiling, it's not symmetric. But all of these conditions were described prior to the association with a chromosome 22q11.2 deletion by clinicians concentrating on specific areas of expertise. So I mentioned that Dr. DeGeorge was an endocrinologist, Dr. Takal in Japan was a cardiologist, and Dr. Sprinson in New York was a speech pathologist. So now 22q11.2 deletion syndrome is the preferred term as the single common denominator uniting all of our patients and their varied presentations. So importantly, we now know that 22q11.2 deletion syndrome is common. It's been identified in 1 in 1,000 pregnancies, 1 in 1,500 miscarriages, and 1 in 2,000 live births, making 22q11.2 deletion syndrome the second most common chromosomal abnormality after Down syndrome. It's the most common cause of syndromic palatal anomalies and schizophrenia, and the second most common cause of major congenital heart disease and developmental delay after Down syndrome. And 22q is not related to advanced maternal age, so affected offspring are equally likely to be born to young mothers as to those with advanced maternal age. So based on a prevalence of 1 in 2,000, there should be about 163,000 affected Americans, including 35,000 children and adolescents, making 22q and 1.2 deletion syndrome an important public health concern. I'll also mention that we have the largest 22q center in the world. We follow about 2,000 patients, so it begs the question, where is everybody else? And we think they're waiting to be diagnosed. Now, common significant associated features include the big three that I already talked about: immunodeficiency, congenital heart disease, and endocrine abnormalities. But you'll see in red that I've highlighted some overlap with TANGO2, including arrhythmia and sudden death in some patients, thyroid disease, hypoglycemia. We also have all the other things that I've talked about a little bit: palatal abnormalities. GI problems are one of the most common issues that we see in young children and the most frustrating for parents, and I'll say the constipation is generally lifelong in almost everybody. We also see differences in the cervical spine and scoliosis, and we see kidney differences. And less frequent but significant features include CNS problems such as idiopathic seizures, which you've heard about, meaning that we don't know the cause of them, unlike when your calcium is low and you have seizures. Dystonia, dysarthria. We see autoimmune disease related to the immunodeficiency, some differences in the genitourinary system, ENT differences including sensory neural hearing loss, which we heard about earlier, and strabismus. And in 22q, we also see an increased prevalence of malignancy, we think associated with that immunodeficiency. Now, associated features related to brain and behavior are broad, so they start out with neonatal seizures, which are usually hypocalcemic, developmental delay and cognitive differences, autism spectrum, attention deficit, idiopathic seizures or epilepsy, as I just mentioned, mood and anxiety disorders, and as I alluded to earlier, schizophrenic and other psychotic disorders, and then more recently, neurodegenerative disorders and movement disorders, including Parkinson's disease. So 22q and 1.2 deletion syndrome is now known to cause additional congenital anomalies, later onset conditions, cognitive deficits, behavioral differences, and psychiatric illness, all far extending the original description of DeGeorge syndrome. And this wide variability often delays diagnosis, including in adults identified only following the birth of a child with congenital heart disease, such as this gentleman on the right. So how do we explain such variability, what I like to say, the tiny piece leading to a big picture? Even amongst identical twins, such as these two fellows who come to see us in Philadelphia from a distance. So the young man on the left had a very complicated heart difference. His identical twin has a normal heart. The one on the left had a palatal difference. The one on the right has a normal heart. The one on the right had thyroid cancer. The one on the left does not. The one on the left had idiopathic seizures. The one on the right has ADD. They have about a 10-point difference in their IQ, and yet the one with the higher IQ has schizophrenia, and the one on the right doesn't. Identical twins, all with the same genes. So we're trying to figure out why there's this variability, and we found that genes on some of those other chromosomes can affect what we find, not in the identical twins, obviously, and we call these modifier genes. So for example, with IQ, you may have a lower IQ because you have the deletion and loss of those 50 genes, but your parents' IQ, your background IQ, may bring that number up higher. And that's true for all of the things we're talking about, including, for instance, congenital heart disease. Now, other features may be explained by dual diagnoses unrelated to 22q. So we have patients with the deletion and another condition. So we have one child who had severe combined immunodeficiency due to something called an Artemis deficiency, which is autosomal recessive, not on chromosome 22. We have somebody with 22q and cystic fibrosis. We heard about somebody earlier with that. With 22q and a bleeding disorder, with 22q and a chromosome difference, 22q is common. So you can expect to find patients with two things. Still, other features may be due to dual diagnoses related to the deletion. So in patients with a deletion on one chromosome, as well as a variant on the remaining non-deleted chromosome 22. And we talked about this earlier. So for example, we have patients with craniosynostosis, and I reported them back in 2005. Craniosynostosis is premature fusion of the bones of the skull, and we need those sutures to be open so that the brain can grow and also so that the head can fit through the birth canal during delivery. But we had patients with 22q and this difference in the skull, and we reported them as an association, but it never felt like it was completely related to 22q. And then a paper came out talking about this gene CDC45 related to craniosynostosis, and we went back to those patients, and we found that sure enough, every single one of them had a change in that gene within the deletion. So it was an autosomal recessive condition unmasked by the deletion. And there are multiple additional examples of such conditions involving different genes within the deletion, again, unmasking an autosomal recessive condition. And they include GP1B beta, SNAP29, I mentioned CDC45, LZRT1, SCARF1, ProdH, and of course, TANGO2. Now, these result in different conditions, including Bernard-Soulier, Sednick syndrome, CGS, autosomal recessive Noonan syndrome, Vanden Ende-Gupta, and proline dehydrogenase deficiency, and they all have their own specific additional problems. But the most significant example in our mind is TANGO2 deficiency disorder. And as you can see from this image, maybe you can't because of the lighting, but in 2015 when I published this paper, we didn't know about its importance. And like CDC45, it's not highlighted in gray, unlike those other genes that I just mentioned. And we only became aware of the devastating impact of changes in TANGO2 on the non-deleted chromosome 22 when we lost one of our own. And Robert had typical features of 22q and was diagnosed at 10 months with all of the things that we're used to seeing, as well as a few things that were not. He had torticollis, he had episodic ataxia versus dystonia, he had difficulty waking following anesthesia, he had staring spells versus seizures, and he had weakness and extreme fatigue, and he also had thyroid disease and was found to have hypoglycemia. And sadly, in 2015, Robert passed following a brief illness. And it took from 2015 to 2018 to make a diagnosis in hindsight. Clinical whole exome sequencing done at a very well-reputable lab was normal, specifically targeting TANGO2, despite calling them several times and saying, "Are you sure there's nothing going on with TANGO2?" But we didn't give up, and an exon 3 to 9 deletion in the TANGO2 gene was subsequently identified in the research lab of Dr. Beata Nowakowska, who's in Warsaw. And no question, having Robert's diagnosis in its entirety was enormously helpful for Robert's family, including his mom, Debbie, who's here in the audience. And it was enormously helpful for his care team, and of course, we only wish we knew sooner. Since Robert's diagnosis, we've identified variants in TANGO2 on the non-deleted chromosome 22 in 8 patients, 6 from CHOP, including 1 patient with an exon 3 to 9 deletion, and 2 from Leuven, Belgium. Findings in these patients are quite variable. All have typical features associated with 22q, but the child with the exon 3 to 9 deletion has some features of TANGO2 deficiency disorder, including head tilt, drooling, fatigue, balance issues, episodic muscle stiffening, but all the laboratory studies have been normal, and we've not noted any crises. One adult has a history of recurrent preeclampsia and pregnancy, and I only bring it up because we know of the association with mitochondrial disease, but I've talked to some of the folks here, and it doesn't sound like anybody's seen that in patients with TANGO2. So when looking at how the gene is expressed in the blood cells, the one patient with the deletion has almost no expression of TANGO2, you can see down on the right, whereas a patient with a missense mutation has decreased expression compared with patients who only had the 22q and 1.2 deletion, but no additional change in TANGO2. So the type of variant likely explains why some patients appear to be relatively asymptomatic. And we're, of course, worried about those patients because we're not quite sure what to do other than now give them B vitamins. Now, we see this variability in expression of other genes within 22q when we expect half the expression compared with controls. So you can see here the red are the controls and the blue are patients who have the deletion. So we see about half the amount of crackle in SNAP29 and LZTR1. But some genes have quite variable expression in general. So we need to continue to consider potential modifiers to explain these differences. And as you can see, it's all over the place with Claudin-5 and TBX1, which if you had the other allele missing for TBX1, it's not compatible with life, DGCR8 and PROD-H. Now, Claudin-5 is particularly important because it's a candidate to explain idiopathic seizures, small head size, some brain differences, as well as schizophrenia. So we're looking very hard at those patients who have very low levels of expression of Claudin-5. So for the entire 22q11.2 deletion syndrome community, identifying the frequency of TANGO2 variants in our patients and how they may impact outcome is extraordinarily important to provide personalized medical management, like with Debbie and her family with Robert, in its entirety, as well as to provide accurate genetic counseling. In general, the 22q11.2 deletion is new in the family. The recurrence risk is quite low. But obviously, if you had a parent, for instance, with the deletion and the partner had TANGO2, then they would have that 25%. Well, not exactly, because it would be 50-50 to give the deletion, but you know what I'm saying. It's an elevated risk compared to somebody who didn't have that TANGO2 variant on the other allele. So no question, working together with the TANGO2 community is the only way this will happen. And that's why I'm so pleased to be here today, and I thank you so much for having me. And I'd like to thank the patients and the families for everything that they've taught us, because just as you've said all day today, it always begins with a patient. And I'd like to thank my collaborators at CHOP and around the globe, because it takes a village to care for a patient with 22q. And special thanks to Debbie for her enormous strength, her warmth, her kindness, her willingness to help others. If you love 22q as much as I do and you haven't booked anything for July, consider coming to our meeting in 2 weeks in Óbidos, Portugal. It's our 13th annual meeting, which is really our 25th anniversary of meeting together to talk about 22q. And we're so delighted to have Sam and Christina there to bring TANGO2 to the 22q community, as well as Debbie, who's going to speak. And thank you for your kind attention.